Although everyone I really wanted to watch because I kind of have like the explain that at all?
What days are you work best for you? Just send me an email with the dates and times that work best for you. I'm here for you. And then we can coordinate the time.
Okay. And then those APs are going to be graded, but not in our mailbox.
She should have put them in the mailbox today. But I think she released the, she released the scores. But yeah, you should have it in the mailbox. Secretary should have put it in.
Okay, thank you.
Yeah, no worries.
As of right now, apparently they have 3 different time schedules.
What are you talking about?
They left our courses left out when they made the final schedule. How do you do that? When I'm just trying to be the donkey. Just kidding. Which lecture are we doing?
Odontogenic tumors. Should be uploaded. Okay.
We're starting.
Can you guys hear me? Yeah. All the way in the back? Okay. So we'll go ahead. So this is my last topic that I'm going to teach you guys. We're going to talk about odontogenic tumors, and basically what I want you to remember when we talk about this topic is how do you correlate, the lesions that we saw on Friday, the cystic lesions, and then the tumors, because radiographically there's a lot of similarities, right? So it's important to make sure that you learn how to, come up with a differential diagnosis when you see something radiographically, because cysts and tumors can both be included in that differential diagnosis. So again, the reason why I put up this photomicrograph again, because odontogenic tumors are also considered developmental, okay? And basically during development of tooth, if there are certain structures that persist even after tooth development is completed, then those can give rise to these odontogenic tumors. And one of the common things that you would, pretty much will come across is the dental lamina. Okay, so as we talk about these tumors, that's one entity that we would see. Okay, so there's a classification scheme for odontogenic tumors, and it's in your handout that's uploaded on Canvas. So depending on what the origin from which these tumors arise, they're classified into 3 big categories, right? So you have tumors that arise from odontogenic epithelium, tumors that arise from mesenchyme, and then tumors that are mixed. So that means they have origin from both epithelium as well as the ectomesenchyme. Okay, so it's a combination or mixed odontogenic tumors. So this would make more sense as we actually start talking about the tumors, what it means to have, an origin from the odontogenic epithelium or mixed origin or just ectomesenchyme. And you also need to know which ones are considered true odontogenic tumors and which ones are just hamartomas. Do you guys remember the definition of hamartoma at all from our neoplasia lecture?
The tumor.
It's not supposed to be there, but it's the word.
Okay, so a hamartoma is basically, it's made up of elements, right? that are native to that site.
Yeah.
So basically, for example, if when we talk about odontoma, you'll understand that terminology much better. The reason why it's called hamartoma because it comprises of elements that are teeth-like, right? It'll have enamel, it'll have dentin, it'll have pulp, but they're not organized enough to actually form a tooth-like structure. Okay, and then it's in the jaw bones, so it's actually native to that site. It's made up of all these elements that are native to that site, but just they are not organized enough to form, a normal structure in that area. Okay, so that's when you call them hamartomas. So it's important to know which ones are considered true tumors and which ones are hamartomas. Okay, in this it's pretty easy. It's basically odontoma is the only hamartoma we're going to talk about in odontogenic tumors. Yes.
Would that be like the certain groups that have like an extra set of teeth? Or
So those are considered supernumerary teeth, right? So they are not hamartomas. So because supernumerary teeth means that the enamel, dentin, and pulp, it organized itself to form a tooth-like structure, right? It's actually, you know that it's a tooth, when you look at it.
Yeah.
Whereas an odontoma does not look like a tooth, but it has all the elements of teeth in there. Okay, so histologically. So just like when we're talking about jaw cysts, I asked you guys to remember which ones are considered developmental and which ones are considered inflammatory, right? In odontogenic tumors, you need to know which ones are considered true tumors, which ones are considered hamartomas, okay? So this is your classification, the table. You don't need to memorize all of these. The ones that you need to remember in each category, I'm just going to tell you guys, and please make sure you remember those under each category. Okay, so under benign epithelial odontogenic tumors, you need to know about ameloblastoma. Okay, both the conventional and the unicystic type. So you need to know that ameloblastoma is a benign epithelial odontogenic tumor. Okay, both conventional and unicystic types. You need to know about adenomatoid odontogenic tumor. I'm just going to call it AOT. Okay. The other one you need to know about is calcifying epithelial odontogenic tumor, CEOT. Okay, so three things: ameloblastoma, AOT, and CEOT. You need to know that these are benign epithelial odontogenic tumors. Under the mixed category, so that means that arises from both epithelial component as well as the ectomesenchyme, you need to know ameloblastic fibroma and odontoma, both compound and complex. Okay. Under mesenchymal odontogenic tumors, you need to know about myxoma and cementoblastoma. Okay, you don't need to know this category, but just remember that you can also have malignancies that can arise from a pre-existing benign tumor, or they can arise de novo. So that means by themselves that you can actually have a malignancy develop in the jaw bones. One of the most common malignancies that you would see in the jaw bones are these. So intraosseous squamous cell carcinoma. So you can actually get a squamous cell carcinoma in a jawbone without involvement of the soft tissue. Okay, so let's talk about ameloblastoma. So this one is really important for you guys. This is something that has a significant clinical impact for a patient. This is even though it's a benign tumor, it's considered a very aggressive tumor. So when a patient gets treated with this, it's basically usually resection. Okay, so if a patient has an ameloblastoma, the treatment for ameloblastoma is resection. Okay, so this has a significant functional and aesthetic impact for a patient. So this is something you need to be aware of. And remember when we ended the class on Friday on jaw cysts, we used the term acronym MACHO. And I said if something presents as a multilocular radiolucency, there are 5 things that typically present as multilocular radiolucencies in a patient's jawbone. Ameloblastoma is one that you have to consider on the top of your differential diagnosis. Okay, so if a patient presents with a multilocular radiolucency in the posterior mandible, one of the entities you have to consider on the top of your differential is ameloblastoma. Okay, and there's different types of ameloblastoma. So you have a conventional ameloblastoma, you have a unicystic ameloblastoma, and you have a peripheral ameloblastoma. So conventional and unicystic, they both arise in jaw bones. Okay, the peripheral one is only in the soft tissue. There is no bone involvement. So it's not very common to see the peripheral type. The most common type of ameloblastoma that you will encounter in clinical practice is the conventional type. So when you guys write down the answer, if you see a multilocular radiolucency in a patient's jawbone, please write down conventional ameloblastoma. Okay, because unicystic ameloblastoma typically presents as a unilocular radiolucency, not as a multilocular radiolucency. Does that make sense? So there's 3 different subtypes of ameloblastoma. You have conventional, unicystic, and peripheral, right? Out of which conventional is the most common subtype, and that's the one that presents as a multilocular radiolucency in the posterior mandible. That's its most classic presentation. Okay, so whenever you see a patient with a multilocular radiolucency in a posterior mandible, please include conventional ameloblastoma in your differential diagnosis. Okay, and unicystic ameloblastoma typically presents as unilocular radiolucency. So again, as I said, it's a very aggressive tumor, unfortunately, even though it's benign. Okay, so this tumor is considered the most common odontogenic tumor, right? So if you don't consider odontoma as a tumor and you consider odontomas as a hamartoma, then ameloblastoma would be the most common one out of all the odontogenic tumors. However, if you are not considering odontoma as a hamartoma and you place it under odontogenic tumors classification, then odontoma is the most common one. Does that make sense? So if odontoma is considered a hamartoma, then that's independent, right? But if odontoma is considered an odontogenic tumor, then that would be the most common one. Okay? But ameloblastoma is extremely common. The likelihood of you seeing this in clinical practice is pretty likely. Okay? So you guys need to be aware of, ameloblastoma and its impact on a patient. So what is the origin? It can arise from dental lamina. It can arise from an enamel organ. It can develop from the lining of an odontogenic cyst. Do you guys remember from cyst lecture what type of cyst, the lining of a type of cyst can transform into an ameloblastoma? It was a cyst that gets associated with usually an impacted tooth.
Yeah,
It's seen around the crown of an impacted tooth, goes from CEJ to CEJ, dentigerous cyst. Okay, so when I say that it can arise from the epithelial lining of an odontogenic cyst, basically it's arising from the lining of a dentigerous cyst. Okay, or if it's a soft tissue type of ameloblastoma, like the peripheral type, then it can arise from the oral mucosa, right? Because there's no bone involvement there. Okay, so we already talked about the classification scheme. So what do you guys see here now? So let's look at some radiographs and then kind of break it apart. So is it
multilocular,
radiolucent, opaque, mixed? It's radiolucent. Why did someone think it was mixed? Are those septations, or is it part of is the tumor making that product?
those are septic.
These are septations, right? So if it's a tumor that's actually making this, radiopaque product, then it's not going to look like this. If you look at the trabeculae, right? So they have what looks like a C shape to them. Okay. So typically that's not something you would see if it's a mixed tumor and that radiopaque material is the one that's being laid down by the tumor. Okay. So here what you're seeing is the C shape to these septations that you're seeing in the radiolucency. So this is considered a multilocular radiolucency. Okay, what is it doing? This multilocular radiolucency? It's displacing the adjacent tooth, right, on the distal aspect. Okay. Anything else? Are these loculations big or small?
Relatively small?
They are larger loculations, right? And I'll show you what the small loculations look like. So these are considered soap bubble type of radiolucency. When you have locules that are really large in size, that type of radiographic presentation is called soap bubble type of radiolucency. Okay, it looks like a soap bubble. When you look at, I'm sorry?
Is it like that?
Okay, I would not encourage you guys to Google images
Okay.
because unfortunately the diagnosis does not always match the clinical pictures.
Okay.
So if you do want to reference pictures, just make sure that you look at an article, from a reputable journal.
Got
Okay, never do that because majority of the times the diagnosis associated with the presentations are not right. Okay, so.
Good to know.
What do you see? So it's a multilocular radiolucency that's basically interradicular, so that it's between the roots of the teeth. And what you see here is large loculation, so that's why we give this term soap bubble kind of radiolucency, right? So whenever you see a multilocular radiolucency, remember we talked about using the acronym MACHO. So M for odontogenic myxoma, which is a type of odontogenic tumor. A for ameloblastoma, which is the conventional type of ameloblastoma. C for central giant cell granuloma, and Dr. Richards will talk about it in her lecture on bone tumors. H for hemangioma. So sometimes you can have hemangioma arise within a jawbone. Okay, and O for odontogenic keratocyst, and that's the one we talked about last on Friday. It's a type of cyst that's, even though it's benign, it's aggressive. Okay. So again, what's happening here? Is this radiolucent, radiopaque, or mixed?
Radiolucent.
Radiolucent. Is it unilocular or multilocular?
Multilocular.
Multilocular, right? And what is the shape of those septations that you're seeing here? It's almost like a C shape, right? It has a curved, it has curvature to it, right? So they're not straight, linear septations, okay? Are these loculations big or small? Pretty large, right? So what kind of descriptive term would you use to describe this radiolucency? A soap bubble type of radiolucency, right? Multilocular radiolucency. Okay? And what is it doing to the teeth in this area? What's happening to the third molar? It's displaced, right? It's actually being pushed into the ramus of the mandible. Okay? Now, what's happening to the second molar there? That's also displaced, but then what's happening to the root of the tooth there? You can see there's some resorption, right? On the distal root, tooth root. Okay, so these are, even as I said, even though these are benign tumors, they're aggressive. So that means they have a tendency to displace the teeth. They can resorb the roots of the teeth, and then they can cause expansion, right? So they'll be both buccal as well as lingual cortical expansion. Okay, and sometimes it can perforate through. Patients can have pain, but majority of the times they're usually asymptomatic. Okay, so because this is a benign tumor, these tend to be pretty slow growing. Okay, so they don't get to this size within a week or two, right? So it takes a long time, a few months, sometimes few years to get to this, to get to this size. So the most common site for a conventional ameloblastoma is the posterior mandible. Okay. And they can be associated with impacted teeth. Okay, so just like dentigerous cyst or odontogenic keratocyst, a conventional ameloblastoma can also be associated with an impacted tooth. Okay, but do dentigerous cysts typically present as multilocular radiolucencies?
No.
No, they usually present as unilocular radiolucencies, right? So that's how you need to kind of learn how to distinguish between different entities that can be associated with impacted teeth. Okay. So here, what do you guys see here in this radiograph? And this is kind of tricky.
A single.
Okay, so where is the pathology here? Is it in the maxilla or mandible? Mandible. Is it posterior mandible or anterior mandible?
Posterior.
Posterior. Okay. Is it where in the posterior mandible do you see the pathology?
The internal oblique line.
Okay. Which tooth? Tell me the tooth number.
Distal third molar.
So it's distal to the third molar, and that's critical. Whenever you look at radiographs or clinical pictures, the first step is identifying where the pathology is, right? Because if you're not looking at the right area, your diagnosis changes. Like when I was grading your quiz, I've noticed a lot of you guys call, instead of physiologic pigmentation, you favored leukoedema. Okay, but leukoedema, and when we looked at the picture, we realized that's not the critical component of that, pathology that we're looking at. And you have to look at the entire, big picture when you make diagnosis, because it could be a difference between, basically making the right diagnosis to something that's completely, irrelevant in that area. So this one right here is your radiolucency, right? So is it unilocular or multilocular?
Unilocular.
Unilocular. Does it seem like it's well defined?
Yes.
It appears to be, right? And is it associated with an impacted tooth? Yes. Okay. And it's on the lateral aspect of the third molar, right? Okay, so if you saw this, what would be on the top of your differential diagnosis?
Okay.
Dentigerous cyst. That's right. Someone said dentigerous cyst. That should be the one that should be on the top of your differential diagnosis, right? Again, there's many other cysts and tumors that can mimic a dentigerous cyst. Okay, but when you see a unilocular radiolucency around the crown of an impacted tooth, either completely surrounding it or on the lateral aspect of it, you have to consider dentigerous cyst on the top of your differential. But again, this is a conventional ameloblastoma. So a conventional ameloblastoma can mimic a dentigerous cyst in its radiographic appearance, right? An odontogenic keratocyst can mimic a dentigerous cyst in its radiographic appearance. So you have to make a short list of things that can mimic dentigerous cyst radiographically and present as unilocular radiolucencies. Okay? So that's how you get to differential diagnosis. Okay, how about this one here?
It's a single
So is it radiolucent, radiopaque, or mixed?
radiolucent.
Radiolucent. Is it unilocular or multilocular?
Unilocular.
Unilocular. Where is the location of this radiolucency? Interradicular. So it's between the roots of the teeth, right? Which two teeth is it seen between? Canine and first premolar. So if you saw a unilocular radiolucency between the roots of two teeth, okay, especially a canine and a first premolar in the mandible, and the teeth adjacent to it are vital, what did I say you have to consider on the top of your differential diagnosis? Lateral periodontal cyst. So lateral periodontal cyst would be one you would consider on the top of your differential. However, this is a conventional ameloblastoma, right? So you can also have a conventional ameloblastoma mimicking a lateral periodontal cyst. Remember, we also had one more example. An odontogenic keratocyst also mimicked a lateral periodontal cyst and was between the roots of two teeth, okay? But the critical thing is the two teeth adjacent to this radiolucency are vital, okay? So if the teeth were non-vital, or even one of the tooth was non-vital, then you have to consider lateral radicular cyst in your differential, okay, because that's an inflammatory cyst. Okay, and this is from your textbook, and you can see varying presentations radiographically. So the one that's right here, this is basically your classic presentation of a conventional ameloblastoma. So what you see here is a multilocular radiolucency, and these are really large loculations. So this is considered a soap bubble type of radiolucency, okay? And what is it doing? It's an aggressive lesion. So it's actually displacing the tooth into the ramus of the mandible. So the third molar got pushed in. And then what happened to the buccal and lingual cortices? They are expanded, right? So you can see this cortical expansion. And it's actually basically, invading the inferior border of the mandible. And it kind of actually, kind of went past the inferior border of the mandible, right? So this would be a pretty expansile lesion clinically when you look at this patient. They'll have clinical expansion. Okay, so here. Now, is this considered unilocular or multilocular radiolucency? Multilocular still. But what is the size of the loculations compared to this one here? Really small, and they're tightly knit to each other, right? So this actually looks like a honeycomb, right? So that's why they use the term honeycomb type of radiolucency to describe these multilocular radiolucencies. If it's really large locules, you call them soap bubble. And if it's really small loculations, you use the term honeycomb. Okay, so these are the two major patterns that you see with conventional ameloblastoma. You can also see them as unilocular radiolucencies, between two teeth. Again, if you see this kind of presentation, you always have to consider lateral periodontal cyst on the top of your differential, but you can also have conventional ameloblastoma and odontogenic keratocyst mimicking a lateral periodontal cyst in that location. This one is extremely rare presentation, so I won't talk about it, okay? So it's not something you'll see in your practice. Yes?
I have a question. So what if a patient had cortical expansion in the anterior mandible?
You can have cortical expansion, and this was an example of that. So this type of ameloblastoma typically affects the anterior mandible. It's a variation of ameloblastoma, histological variant called desmoplastic ameloblastoma. I didn't want to talk about it because it's extremely rare, and it's not something you're likely going to encounter in your clinical practice. But yes, it can affect the anterior mandible and it can cause expansion in that area. But there's other things too that can affect anterior mandible that can cause cortical expansion, like a central giant cell granuloma, which is much more common and that's seen in younger patients. But that's Dr. Richards is going to cover that. Okay, so histology, this is one entity I want you guys to know the histology for, okay, in the odontogenic tumors. So critical things in histology for an ameloblastoma is recognizing this pattern here, okay? So what do you guys see here? What is that blue, really dark blue structure inside the cell?
That's the nucleus.
That's your nucleus, right? So is the nucleus usually towards the basement membrane or is it away from the basement membrane? It's towards. Usually nucleus is towards the basement membrane, okay? In ameloblastoma, it exhibits what's called reverse polarity. So that means the nucleus moves away from the basement membrane, okay? So rather than being here, now it's more towards the lumen of this, structure, okay? So this is called reverse polarity. And if you look close enough, this area that's below the nucleus within the cell sometimes can have vacuoles in them, okay? So they can have subnuclear vacuolization. So if you see this pattern, okay, so if you see islands like this, okay, and then you have a nucleus that's moving away from the basement membrane, and then you can see vacuoles in this, space between the nucleus and the basement membrane, and the center of it, if you look at this, looks like stellate reticulum. Okay, you remember in embryology we were looking at the term stellate reticulum between inner enamel epithelium and outer enamel epithelium. So the center of these ameloblastomas mimics that stellate reticulum. Okay, and that's why we know that this is an odontogenic tumor of odontogenic origin. So critical things histology-wise is reverse polarity, subnuclear vacuolization, and that stellate reticulum in the center. Okay, so if you see those, then you have to make a diagnosis of conventional ameloblastoma. So unfortunately, as I said, conventional ameloblastomas, they have a tendency to infiltrate the bone, okay? And what happens is, the way they infiltrate, before, it takes a little longer for it to be radiographically visible, that infiltration and destruction of the bone in an ameloblastoma. So typically the recommendation, what the surgeon recommends, is when an ameloblastoma is being treated by resection, they usually go at least 1 to 2 centimeters past what they're seeing radiographically as the margin of the tumor. Okay, you have to have at least 1 to 2 centimeters beyond what you're seeing as a tumor radiographically when it's being surgically resected, because the likely possibility is this tumor infiltrates into the bone, and then it may not be radiographically visible, but it's still doing it, underneath. Okay. So typical treatment for this is marginal resection. Some have tried doing curettage, but then when you treat ameloblastoma with curettage, the recurrence rate could be as high as 90%. Okay, so it is not the most effective treatment. So the best treatment for conventional ameloblastoma is resection. Okay, and you have to do 1 to 2 centimeters past radiographic margins, and the recurrence rate usually is at the most 15%. Okay, so this is what you would see. So when this is typically the treatment for a conventional ameloblastoma. So you have what looks like a multilocular radiolucency. These are really large loculations, so it's a soap bubble type of pattern. It actually, displays the teeth in this area. But again, what did they do here? They basically went, way more than, what you're seeing as a radiographic presentation of the lesion, right? Because that's your lesion right there. Okay, but then they went all of this extra bone, around, right? So you have to go at least 1 to 2 centimeters past your radiographic margins to make sure that you got the entire lesion. So this is what it would look like. Okay, so again, same thing. So you have what looks like a resected specimen. So this is a resected mandible, a partially resected mandible, and then this is the tumor. Okay, so here you have some areas that look cystic, and this is the solid component of the tumor. So this is what we saw as those islands histologically. If I took a sample from here and looked under the microscope, that's basically what I'm going to look at. Okay, and then you can also have some areas that look predominantly cystic too, and that's why you get this multilocular kind of appearance radiographically with these lesions. Okay, so but the typical treatment is resection. So that's why it's critical. Whenever you see someone with a multilocular radiolucency, you have to, especially if you're entertaining the diagnosis of a conventional ameloblastoma, it's really essential that you refer this patient to an oral surgeon right away because the treatment for it is pretty aggressive. And this is a benign but aggressive lesion. Yes?
How fast does the lesion spread?
They're very slow growing tumors.
Very slow.
So they take a long time to get to that size. So ideally, if you see some radiographic changes in a patient's bone, don't sit on it, don't wait, because they can transform into something like that. So this is another type of ameloblastoma, which is called the unicystic ameloblastoma. And this is not as common. It's only about, at the most, 20% of all ameloblastomas end up being unicystic type. But 75% of them end up being the conventional type, the one that we have seen before. Okay, so unicystic ameloblastoma can arise either from the lining of a cyst, okay, can transform into a unicystic ameloblastoma, or it can just arise by itself without any transformation from a lining of a cyst. So what do we see here? Is it radiolucent, okay, unilocular radiolucency surrounding
The pericoronal
the crown of a impacted tooth, right? It looks like a third molar, okay, and it's basically going this way. And does it have a corrugated border?
Yeah.
Yes, okay. So if you saw that, what should be on the top of your differential?
Dentigerous
cyst, okay. But again, as we learned, that there's many things that can mimic a dentigerous cyst. So this one happened to be a unicystic ameloblastoma. So unicystic ameloblastoma typically presents as a unilocular radiolucency. It never presents as a multilocular radiolucency. So if you get a diagnosis back as a unicystic ameloblastoma for something that looks multilocular radiographically, please question your pathologist, okay, because that's not correct. It usually presents as a unilocular radiolucency, okay, and it mimics dentigerous cyst most commonly. And this is typically, it tends to be seen in younger patients. So usually you see them before like their second decade of life, okay. So conventional ameloblastoma tends to be a little bit older at, patients. So usually after second decade of life is when you see conventional ameloblastoma. It's really rare to see a conventional ameloblastoma in patients younger than 20 years of age. But it's much more common to see unicystic ameloblastoma in patients younger than 20 years of age. Okay, again, this has a predilection for posterior mandible. There's 3 different subtypes of unicystic ameloblastoma. One is called luminal, the other one is intraluminal, and then mural. So, and this is more histologic difference. Okay, so the reason why this is important because when you look at a luminal ameloblastoma, unicystic type. Basically what it's doing is, it looks like a cyst typically, okay? But the lining of that cyst is made up of cells that look ameloblastic, okay? So that's why it's called unicystic ameloblastoma, but with just, affecting only the lining. If that lining starts proliferating into the center of the cyst, that means into the lumen, you call it intraluminal. If this lining starts budding, right, and then starts separating, and then starts going into the fibrous wall of the cyst, then you call it mural. Mural, unfortunately, behaves just like a conventional ameloblastoma, because now from just the epithelial lining of the cyst wall, it's separated and then it lodged itself in the fibrous wall, right? So because of that, it tends to behave a little bit more aggressively. Okay. How do we treat a unicystic ameloblastoma? Because this is a cystic lesion, right? And it has this significant epithelial lining. You tend to just basically treat it with enucleation. Okay, so you have to completely remove the lining of this tumor, from the jawbone. Okay, but this requires long-term follow-up. Why? Because when you do enucleation and just curettage the bone, what happens is recent studies, when they looked at the recurrence rate was as high as 60%. So patients, got this lesion back again 60% of the times. Okay, so the thought process nowadays is, if it comes back as a unicystic ameloblastoma in your incisional biopsy, then basically just go back and enucleate and be conservative in your treatment. If the lesion recurs, right, then they become a little bit more aggressive in the treatment. So that means they'll do a resection. Okay, so initially they go with conservative therapy, which is your enucleation and long-term follow-up. And then if the lesion recurs, then they become a little bit more aggressive and then do resection for these lesions. Okay, so when we look at ameloblastoma, basically they are considered benign odontogenic tumors. And what type of tissue do they originate from? Is it epithelium, ectomesenchyme, or is it mixed origin? Epithelium. So it's a benign epithelial odontogenic tumor. Okay. And what are the three different subtypes of ameloblastoma? Conventional, unicystic, and peripheral. Okay, or extraosseous. Okay, so conventional can be a solid type like the picture that we saw, or multicystic type. Okay, but as long as it's a conventional ameloblastoma, that's fine, and that's the most common subtype. So conventional ameloblastoma, what's the most common radiographic presentation? It's multilocular radiolucency. So when I say what is the most common radiographic presentation? You need to tell me it's a multilocular radiolucency. Okay? And what is the most common site for a conventional ameloblastoma? Site of occurrence? Posterior mandible. Okay? And what is the most common age for a conventional ameloblastoma? It's older than 20 years of age, right? So basically less than 40 but over 20 is typically the age for conventional ameloblastoma. How do you treat a conventional ameloblastoma? Resection. It's really critical. Please use the term marginal resection. If I ask you what is the treatment for conventional ameloblastoma, you have to tell me it's resection. Okay? Do not write excision, do not write, incision, curettage, enucleation, none of those. The treatment for conventional ameloblastoma is marginal resection. And what is the margins that you have to take when you're resecting this lesion? So it's 1 to 2 centimeters past your radiographic margins. Okay, so that's critical. What is unicystic ameloblastoma typically present as radiographically? Unilocular radiolucency, right? So what cyst does it commonly mimic, a unicystic ameloblastoma? A dentigerous cyst. Okay, so and what is the most common site for a unicystic ameloblastoma? Posterior mandible. Is it common in patients younger than 20 years of age or over 20 years of age? Younger than 20 years of age. Okay, so the next entity, which is also an odontogenic tumor, which is also benign, and it's also epithelial in origin. So this is a benign epithelial odontogenic tumor. It's called AOT, or adenomatoid odontogenic tumor. Okay, this is not very common. It only comprises 2 to 7% of all odontogenic tumors, but it has a very classic presentation. And when you see this, you should be able to make, a diagnosis with these, or at least it should go on the top of your differential. So this can arise from enamel organ, from dental lamina, from reduced enamel epithelium. All of these components during teeth development can give rise to an AOT. This is not the greatest picture. Okay, what do you guys see here?
Crooked teeth.
What is that too?
Impacted. Horizontal
Canine,
impacted.
right? So it's a horizontally impacted maxillary canine. What is around that too? That's actually a radiolucency. It's a unilocular radiolucency around the crown of an impacted canine. Okay, so AOTs, or adenomatoid odontogenic tumors, these are the things I want you to remember. It usually is seen in association with an impacted maxillary canine. So this is very different, right? Everything that we have studied so far, they tend to have predilection for posterior mandible with the third molars. But AOT has a predilection for impacted maxillary canine, and it's usually seen in teenagers and females. So if you see a patient who's a teenager, who's a girl, and has what looks like a well-defined unilocular radiolucency around an impacted maxillary canine, please consider AOT in your differential diagnosis, which is adenomatoid odontogenic tumor. Okay, so that's majority of the tumors, those AOTs, that's the predilection. Females, teenagers, impacted maxillary canine. Okay, they typically are asymptomatic. So there's a couple of different ways that it can present radiographically. This is a little better. You can see this again as a radiolucency around an impacted tooth, right? This is pretty well delineated. So this is called a follicular type of radiolucency. Okay, so in follicular type, what it means is it mimics like a follicular cyst or a dentigerous cyst. So it's just around the crown of an impacted tooth. Occasionally, you can see it between the roots of two teeth. Again, what is this mimicking? Lateral periodontal cyst, because that's your canine, that's your lateral incisor, right? And then you see interradicular as a unilocular radiolucency. So occasionally an AOT can mimic a lateral periodontal cyst. This is called the extrafollicular type of presentation. Follicular basically means it's around the tooth, right, the crown of the tooth. But in AOTs, that radiolucency sometimes can go all the way down to the root of the tooth. So usually with a dentigerous cyst, it does not extend all the way to the tip of the tooth, root tooth. Okay, so even if it goes along the tooth root, it stops kind of halfway along the tooth root. Whereas in an AOT, it can actually, encompass the entire tooth. Okay, or you can have a radiolucency with some really fine radiopaque calcifications in them. So you see this, it looks kind of radiopaque, especially on the mesial aspect of that, on the distal aspect of that tooth. So right there. So these are radiopacities inside a radiolucency. So this type of radiographic pattern, it's called snowflake calcifications. It mimics snowflakes. Okay, so this is something that's typical of an AOT. Okay, and you can see it in about 1/3 of cases of AOT with this kind of calcifications. Okay, so 3 different radiographic patterns in an AOT, which is it can be seen as a follicular type, so surrounding the crown of the tooth, or it can go all the way down to the tip of the tooth root. Okay, or it can be seen as an interradicular radiolucency between the roots of 2 teeth. These 2 teeth are going to be vital when you test them. Or it can be seen as a mixed radiolucency radiopacity with these calcifications. What was the cyst that we talked about that appears as a mixed radiolucent radioplaque lesion on Friday? There's only one of them that we said can appear mixed. OKC is not the answer for everything. That would be nice. COC, calcifying odontogenic cyst, because it has the term calcifying, right, in it. So it's a calcifying odontogenic cyst. Okay, so calcifying odontogenic cyst is a cyst that presents as a mixed radiolucent radiopaque lesion. AOT can present as a mixed radiolucent radiopaque lesion. So again, I would make a short list of things that can present as mixed radiolucent radiopaque lesions. So entities that can present purely as radiolucencies, out of which ones present as unilocular, which ones present as multilocular. Again, entities that present as mixed lesions. Okay, makes your life a lot more easier when you can make a small differential diagnosis list. Okay, so here is how it presents clinically. So sometimes you can have in the area where there's the tumor, you can have significant swelling, right? And then this is what you would see with surgery. So basically AOTs, they tend to have a capsule around them. They're benign tumors, and remember, one of the features we talked about benign tumors is they tend to have a fibrous capsule around them, right? So AOTs have a fibrous capsule around them. So when you try and take this out, it comes out nicely in one piece because of the capsule. Okay, so it shells out easily. AOT. So this is histology. Don't worry about it. We're not going to focus on that. And then treatment is enucleation, and they rarely come back. Okay, so AOT is also considered a benign epithelial odontogenic tumor. Critical things to remember is it's seen in teenagers, in females, commonly associated with impacted maxillary canine, and there's 3 different radiographic presentations. It can be seen either as a radiolucency around the crown of a tooth, going sometimes all the way to the root of the tooth. It can be seen as a radiolucency between the roots of 2 teeth, that's interradicular, or it can be seen as a mixed lesion, both radiolucent and radiopaque. Okay, and the way you treat it is just enucleation, and these are benign tumors. Okay. Let's do this one and we'll take a break. Okay, so this is the last epithelial odontogenic tumor that we'll talk about. So this is called calcifying epithelial odontogenic tumor. So again, odontogenic tumor is the common thing that kind of, you're seeing with all of these entities. It's epithelial in origin, so that's why it's considered epithelial odontogenic tumor. But this tumor actually has calcifications in it. Okay, so that's why it's a calcifying epithelial odontogenic tumor. The other name for it is Pinberg tumor. Okay, but please don't use the term in your exams. Use the term calcifying epithelial odontogenic tumor. This is not something that's commonly used anymore. This is not very common tumor. It's only less than 1% of all odontogenic tumors are actually CEOTs. Okay, the origin again could be from a dental lamina. So what do we see here? This is not the greatest radiograph, but I want you to focus here.
Honeycomb.
So it looks like as a multilocular radiolucency, right? And it seems to be between the roots of 2 teeth, okay? But it's a pretty expansive lesion. Okay, so it's going all the way to the inferior border of the mandible. So CEOTs typically present as multilocular lesions. Okay, again, this is not extremely common tumor. So this is not something that I would consider on the top of my differential diagnosis if a patient presents with a multilocular radiolucency. You have to think of ameloblastoma, OKC, you have to think of myxoma, all of these things before you think of CEOT, unless and until there's something in the history that tells you that, this is a CEOT. Occasionally, you can also have they can either present as multilocular, but you can also see them as mixed radiolucent radiopaque lesions. So again, AOT is one that presents as mixed radiolucent radiopaque lesion. CEOT is another one, which is your calcifying epithelial odontogenic tumor that also presents as a mixed lesion. Okay. So you would basically see it clinically as an expansile lesion here. So you can see that there's lingual expansion. okay, into the floor of the mouth. And then here you can see this lesion right here, right? So what kind of a radiographic presentation is this?
Unilocular.
Would you use the term unilocular for this one? When you see these?
Yes.
What are these? Calcifications, right? So this is considered a mixed lesion. You only use the term unilocular or multilocular if they are purely radiolucent. Okay, you cannot use the description unilocular just because it looks like one big locule. Okay, this is a mixed lesion. So you see what looks like a radiolucency mixed with radiopacities, and the radiopacities seem to be more in the center of the lesion, right? And this is a pretty well demarcated lesion superiorly, and you have a corrugated border. Okay, so they can present as mixed lesions, the calcifying epithelial odontogenic tumors. Okay, or this is again the most common presentation, right? And this is from your textbook. You can see that it presents as a multilocular radiolucency. If you saw this, would you consider CEOT in your differential diagnosis on the top? When it's growing anteroposteriorly like this, what entity would you consider anteroposteriorly growth direction? This is where your favorite answer would come in. OKC. So it would be odontogenic keratocyst. Okay? So odontogenic keratocyst basically presents as a multilocular radiolucency that grows anteroposteriorly like this. Okay, but then this is actually a calcifying epithelial odontogenic tumor. So that's why it's critical to make those short lists and say everything that presents as a multilocular radiolucency and how do you differentiate between them. Okay, so calcifying epithelial odontogenic tumor tends to be more common in adults, right? So it's mostly over 30 or 40 years of age. Okay, whereas conventional ameloblastoma tends to be a little bit more younger. So it tends to be usually, anywhere between 20 to 40 years of age, usually in that 20-year kind of age group. But they both have a predilection for posterior mandible. Okay, so again, this presents as a radiolucency, but this is the honeycomb type of appearance. Again, this would be hard to differentiate. So if you have this presentation, now you have to, if I ask you to give me a differential diagnosis, and what would you include on the top of your differential? You would consider conventional aminoblastoma on the top because that's much more common than a CEOT. Yes?
So you can distinguish OKC based on the age? Or?
So OKCs tend to be more common in younger patient population, but OKCs tend to have an anteroposterior kind of growth pattern, whereas CEOTs, they tend to go usually buccolingually, okay, like an ameloblastoma. So again, in the order of, preference, right? Which one is much more common, OKC or CEOT? OKC is much more common. So if I'm asking you to give me a differential diagnosis, then you have to, and if I say, then you give both of them in your differential, right? If the age and everything, location, everything fits in the radiographic presentation. However, if I ask you what is it that you're going to include on the top of your differential, then you should say either conventional ameloblastoma or an OKC, depending on what it looks radiographically, because they are much more common than a CEOT. Okay? So context is what matters, when you guys read these questions. Okay, so what's critical about CEOT? So if you had that radiograph, and this is what I give you as a histology picture, okay? So the main thing, critical things to remember the words in your histology is what's called amyloid kind of material. So this pinkish material that you're seeing there, that's called amyloid, okay? And then they typically turn into, let me get this to move, these calcifications right here. These are called laser gang ring calcifications. They look like little onion rings, okay? So they're very concentric kind of rings, that kind of calcification. So if you see those calcifications and the amyloid kind of material, then you have to consider, CEOT in your final diagnosis. Okay. So these are less aggressive than an aminoblastoma. They are also treated with resection, but you don't take as much of the bone as you would in amyloblastoma. You take a very narrow rim of bone. Okay, the recurrence is pretty low, and it has a good prognosis. Okay, why don't you guys take a 10-minute break, and then we'll come back at right a little after 2.
So for me, when I am studying this, it would be best for me to get everything laid out, see which ones are most common.
Yes.
And then ages.
Age helps for some things, not for everything. So it all depends on the context, right? So the main things that you, when you make a list, the things that you look for is whether it's radiolucent, radiopaque, or mixed. That's your broad category first, right? Once you have radiolucent, radiopaque, mixed, let's. Do you have a paper? I can just write down. So the way you would do it is first whether it's radiolucent, radiopaque, or mixed. Right? If it's radiolucent, you're going to say is it unilocular, is it multilocular. Okay? Now if it's unilocular, is it pericoronal? Is it interradicular? Is it periapical? Okay, now you look at your list, right? So now we say first, let's start with dentature cyst. It's usually pericoronal unilocular radiolucency. Okay, OKC can be pericoronal. It can be interradicular. So when you read about OKC, you start seeing what patterns match it, right? Rarely it's periapical, but this is not the most. OKC, it can be seen as periapical, but that's rare. Okay, but it's commonly seen as, this is its common presentation, multilocular, right? And then what else? Lateral periodontal cyst, right? That's interradicular. This is the more common one. Okay, so that's how I would do it.
Okay.
Now you say, okay, how do you differentiate between lateral periodontal cyst and OKC? What features do you look for to separate them out? So now you have a short list of things, and then whether does age help to differentiate? If yes, then yes, you should use it. If sight helps to differentiate, yes, you should use sight to differentiate. You know, sometimes you may not be able to differentiate. Then you say it's a differential diagnosis, because you can't give a definitive diagnosis.
Right, and you probably wouldn't ask.
Exactly.
Okay.
Did you ask how to differentiate it?
Well, yeah, as I was going over and following along, I'm realizing this is different from how I have been studying for all of the oral path.
Yep.
So-
And you can apply the same kind of algorithms for soft tissue lesions too, right? So you say, okay, if you have red and white lesions, for example, okay, so you say lesions that appear red, lesions that appear white, lesions that appear red and white combination, right? Now if it's red, now you say, okay, what kind of, is it smooth, you know, red appearance? Is it kind of lobulated? And what is the location? Am I seeing it on the lips? So you can do it as lips, you can do it as tongue, you can do it as palate by locations, and then say, okay. Or another pattern that some people use, which I prefer, is clink. Okay, so C for congenital, so anything that's congenital, developmental, or hereditary. L is for lichen planus or immune-mediated conditions. Okay, I for infections, N for neoplastic, and K is for keratosis. Keratosis means anything trauma-related, right? So now you can say, okay, you look at this category. So what are the congenital lesions that can present as red lesions? What are the immune-mediated lesions that present as purely red lesions? What are the infections that present purely as red lesions? So for example, Candida would be an infection that presents purely as a red lesion, right? And then it can also present as, exactly. So it can also present as white lesion, which is the pseudomembranous type. or it can present as red and white lesions because some areas can look red, some areas can look white. So it can be both pseudomembranous and erythematous candidiasis. Okay, so then you put it in all. So when you read about candida, you just do that. So you can apply the same methodology to anything.
Awesome. Thank you so much.
No problem.
Thank you. That was my question too.
Is it okay if I ask a question?
Go for it.
I'm a little bit confused when we see ultra means it's
What do you mean? What did you say?
when we see it on the images it's a cyst, so it's odontogenic and then separate two different things, or no, it's amyloblastoma and then separate two different things.
No, so the critical thing is not making a diagnosis right away. The main thing is when you see on a radiograph
Okay.
a radiolucency,
Lucency, yes.
right? Then you have to pick what kind of radiolucency is this. Is it unilocular? That means does it have just
one,
one locule?
yes.
Or is it multilocular? That
Is that
means
part
does it
right
have
with the
multiple
brain?
Got it.
locules that are clustered together,
Okay.
right? So once you see that on your radiograph, imagine this is your exam or a quiz, right?
Got it.
That's the picture that you have. Now you decided that this is a multilocular radiolucency.
Okay.
So that means it has multiple
Multiple
locules
part.
and it's radiolucent. Now you have to see is it in the anterior mandible or
posterior.
mandible. Okay, so now this picture that you have is in the posterior mandible multilocular radiolucency. So if it presents as a multilocular radiolucency, then I would ask you to remember the acronym MACHO, right? So there's 5 things that commonly present as a multilocular radiolucency. There's other things that present as multilocular too. So for example, CUOT that we just studied,
Got it.
the calcifying epithelial
Yes.
tumor can also present
This
as a
one.
multilocular radiolucency, but it's not the most common one.
The most
right?
common one is this
The
one.
most common one is ameloblastoma in a tumor.
When it has
Also-
different windows, that means it's gonna be this one or this one.
Or it can be a myxoma. You can
Down.
scroll up into your classification, it can be myxoma. Remember macho, M for myxoma.
Myxoma.
So myxoma can also present as a multilocular
Different
radiolucency.
windows, okay.
Different locules, exactly. Ameloblastoma can present as a
Got it.
multilocular. A CEOT can present as multilocular radiolucency. Okay.
It's gonna be this one.
Yep. Okay.
Or
and
in this one.
All three of
Thank
them.
you
All
so
three
much.
tumors can present as multilocular.
Okay, when I
But
see
out
it's
of
windows,
these-
it's gonna be those three.
But or it can be a cyst, like an odontogenic keratocyst, right? That can also, like the last lecture, and that's why you have to make like a short list and say everything that presents as multilocular radiolucency.
Got it.
Okay. Out of which is the most common one, ameloblastoma is the
one.
most common tumor that presents as multilocular.
Okay.
And then OKC is the most common cyst that presents as a multilocular radiolucency. So those two are going
the
to be
most
high on
common.
your list.
Got it, okay.
But if that multilocular radiolucency has a cloud shape to it, CLOUD cloud,
Okay.
type of a radiolucency, so it's going anteriorly to posteriorly,
Okay.
doesn't cause expansion much, then between ameloblastoma and OKC, it's more likely to be OKC.
Okay.
Does that make
Look
sense?
like a cloud. Okay.
Yeah.
Okay.
So that's how you kind of
Thank you so much.
differentiate.
Thank you.
Okay, guys, we're gonna go ahead and get started. Okay, so our next entity that we're going to talk about is not a benign epithelial odontogenic tumor. This is actually a mixed tumor, right? So if you look at the diagnosis here, what does it have? What are the two? Okay, we need to settle down quickly because I'm going to get started. Okay, so what are the two things that we see here in the term? Ameloblastic and fibroma, right? So ameloblastic, we know ameloblastoma is basically epithelial in origin, right? What does fibroma mean typically? This is not what's going on here, but I just want you to kind of break down the terms.
It's soft connective tissue.
Fibroma means it's connective tissue origin, something to do with fibrous tissue, right? So this has both epithelial component and it has a connective tissue component. So that's why this is considered a mixed tumor, right? So it's both epithelium and mesenchymal tissues are both neoplastic. Okay, this is not very common. The likelihood of you seeing this in your practice is going to be pretty remote. But again, you need to be aware, and this is not a subtype of ameloblastoma. Please do not get confused. This is not a subtype of ameloblastoma. Even though it has the name ameloblastic fibroma in it, this is not a subtype of ameloblastoma. Okay, so that's critical. Because if this is a mixed tumor and not an epithelial tumor, and ameloblastomas are epithelial tumors. Okay, the reason why you use the term ameloblastic fibroma for this entity is because when you look under the microscope histologically, the islands look like ameloblastoma. That's why we use the term ameloblastic fibroma, because it mimics an ameloblastoma histologically. Okay, makes sense? Some people think that this is just an early stage of odontoma, like the hamartoma, right? There used to be another entity called ameloblastic fibrodontoma in the literature. They kind of took that away because they think it's just a stage in the formation of an odontoma. Okay, so what do you guys see here? So this is the radiolucency. This is not, so we cannot use the term mixed and multilocular in the same sentence. Why? Because when you say multilocular, you're basically saying this is radiolucent.
Yeah.
When you're saying mixed, you're basically saying it's both radiolucent and radiopaque. So it has to be either of those two, not both, right? So is this radiolucent or mixed?
Mixed.
Radiolucent.
Oh.
Okay, so that's critical, and that's why it's important to recognize what pattern are you looking at. Because if you guys thought this was a mixed lesion, it completely changes your differential diagnosis, right? But this is a radiolucent lesion, but it's multilocular. So each of these are different locules, and you have these septations, right there. So that's your curvilinear septations that you're seeing there, similar to an ameloblastoma. Okay, so it's between the roots of two teeth. It's actually taking the space of a tooth that's missing in that area. So ameloblastic fibromas, yes.
So if we see the septations pretty clearly, like we can see there, would we be better off saying radiolucent?
Yeah, so this is septations. This is not a product that's being laid down in the tumor, right? So when you're seeing those nice curvilinear septations, you have to say this is a multilocular radiolucency. You cannot call this mixed because it's not a radiopaque particle that's being laid down by the tumor or the cyst. Okay? So this is a multilocular, but typically ameloblastic fibromas tend to be common in younger patients. Okay? So they're usually common in patients younger than 20 years of age. Okay, so there were three entities that we've studied so far today that are younger than 20 years of age. One was unicystic ameloblastoma, the other one was adenomatoid odontogenic tumor, and ameloblastic fibroma. All three of them are seen in patients younger than 20 years of age, most commonly. Conventional ameloblastoma and CEOT are the ones that are commonly seen in patients older than 20 years of age. They tend to be commonly associated with unerupted teeth, but again, this example is not, so you always have exceptions to the rule. But they tend to be more common in posterior mandible. Okay, so here, this is actually associated with a second molar, right? So what's happening here? Is it radiolucent, radiopaque, mixed? Okay, is it unilocular or multilocular? Multilocular. And where are your locules? 1, 2, 3, and there's something on the top, 4. Right? So you have really large, big loculations, but these are your big locules right there. Okay, so this is multilocular radiolucency. So this would be more of that soap bubble type of radiolucency, right? And what is it doing to the second molar? It's displacing it inferiorly, right? So that's important. So this is actually the lesion is pushing the tooth, to a different position. So ameloblastic fibromas typically present as radiolucencies. They are commonly seen in posterior mandible, and they're commonly seen in patients younger than 20 years of age. Okay, and they're mixed lesions. So, and a lot of times they get associated with an unerupted tooth, but there are exceptions to the rule, and this one is not associated with an unerupted tooth, but it's interradicular, and it's actually displacing the two adjacent teeth right next to it, right? So those two teeth are moving in opposite directions. Okay, so why is this called an ameloblastic fibroma? Is based on the histology. So if you see here, what does this mimic? This is similar to the ameloblastoma example that we have seen before, right? So what do we see here? Is that reverse polarity. So the nucleus, there's a little bit of a gap between the nucleus and the basement membrane. Let me see if I can use my arrow. So right there, if I can get this. So here, there's a tiny gap between the nucleus and the basement membrane. So this is called reverse polarity. And same thing here. That's your basement membrane, and there's a tiny gap between the nucleus and the basement membrane. So that's reverse polarity, right? So this looks like an ameloblastic island right here. But then if you look at the stroma, does it look pink in color or blue in color? What kind of a hue does it have? Pinkish hue or a bluish hue? Blue, right? So if it has a bluish hue, that basically indicates that this is more immature. Remember, this is seen in patients that are younger than 20 years of age. So the stroma is a little bit more immature. Okay? So the fibrous connective tissue looks like immature stroma. Okay? So that's why this is considered ameloblastic fibroma, because both the epithelial component and the connective tissue component are both neoplastic. Okay? So the stroma looks immature, and then the islands mimic ameloblastoma. This is considered a fairly innocuous lesion, but the problem that they've encountered is when they just did curettage or they just did a local excision, these came back, significantly, right? The recurrence rate was anywhere between like 18 to 45%. Okay, and this is not good. So what they think is, maybe it's not as innocuous as they originally thought this is supposed to be, right? So maybe this is a fairly aggressive lesion. So what they try and do is, if it's an initial presentation, it's a first-time presentation, they try and treat it conservatively, okay? But if this lesion recurs, then they go back and do more aggressive resection for these patients with ameloblastic fibroma. And they're a little bit more conservative in the initial treatment because, again, patient population that you deal with that ends up getting an ameloblastic fibroma is a younger patient population, right? So you don't want to cause something that's, cosmetically disfiguring for that patient if we can get away with something that's more conservative, treatment. Okay. Okay, so this one, I want you to pay attention. This is really common. This is something you'll encounter in your clinical practice. This is a very common radiographic presentation that you tend to see. These are called odontomas. Odontomas are not considered true tumors. Okay, they are considered hamartomas. And I'll explain to you why they are hamartomas, because when we look at the radiograph and we look at the histology, it'll make more sense why they're considered hamartomas. Okay, they are extremely common. If you combine all of the odontogenic tumors, everything that we saw in that first table, the prevalence of all of them combined, this actually exceeds that, the prevalence of odontomas. So it's very, very common to see odontomas, and you will encounter this in your clinical practice. Okay, but these are benign lesions. They're not malignant, they're not cancers. So it's not going to have, that kind of an impact for a patient. There are two types of odontomas, a compound and a complex odontoma. Compound odontoma is the more common subtype, okay? And in your quizzes and examination, you will have to specify the subtype of odontoma, okay, when you write it down, the answer, because they have a very characteristic radiographic presentation. So you need to be able to distinguish between a compound and a complex odontoma, okay, radiographically. So what do we see here? And this is what I mean by characteristic radiographic presentation. This is not something you see with anything else that, you know, we've talked about so far, either cysts or tumors, right? What do we see here? Where is the pathology? Is it, what part of the jaw? Is it maxilla or mandible?
The maxillary.
So this is maxilla, right? Where's the pathology? Right maxilla or left maxilla? Right. Okay. Right. Patient's right. Now, what is the pathology here? Is it a radiolucent lesion, radioopaque lesion, or a mixed lesion? You guys have to make up your mind. Is it radiolucent, radioopaque, or mixed? And this is critical.
Mixed.
So, okay, I hear mixed, and I'll go with mixed. Okay? So this is actually a mixed lesion. And why is it a mixed lesion? Because it has both radiocapacities and radiolucency around it. The radiolucency that you see in a compound odontoma is just a radiolucent rim around. Okay? So the center looks radioopaque, but it always has a peripheral radiolucent rim. And that's critical to remember. There's two entities that have that in odontogenic tumors that we talk about that present as central radiopacity with a radiolucent rim around them. One of them is an odontoma. Okay? This is a compound type of odontoma. This is the most common type of odontoma that you'll encounter is the compound type. What do we see here? Do they look like one big radiopacity or multiple radiopacities? Multiple, right? So it looks like one, another one, another one, another one. So you have multiple radiopacities. They look like tiny little teeth. Okay? So, and the center of this radiopacity, this area right here, looks kind of radiolucent. So that's actually the pulp. Okay? So it has all the elements of a tooth. It'll have enamel, it'll have dentin, it'll have pulp, but it's just not organized enough to actually make it look like a tooth. Okay? And it's seen in the jawbones. That's where typically teeth are supposed to be, right? So that's why this is considered a hamartoma. So it has all the elements of it, but they are not organized or structured to form normal structures in that area. Okay? But it's seen in an area of the mouth where it's supposed to belong. So that's why this is a hamartoma. So this is a compound odontoma. And what you see here is a central radiopacity surrounded by a radiolucent rim. And these are multiple tiny radiopacities with a central radiolucency in them. And that central radiolucency is the pulp. Okay. And they have a predilection for anterior maxilla. Compound odontomas tend to be more common in anterior maxilla, and complex odontomas tend to be more common in posterior mandible. Okay, what do we see here?
Mixed.
This is a mixed radiolucent radioopaque lesion. And you have what looks like multiple radiopacities, right? They look like teeth-like structures, okay, and they're surrounded by this radiolucent rim. But what is it doing to this tooth here?
Impacting it.
It's preventing the eruption of that permanent tooth, right? And that's usually what happens when you see an odontoma, okay? It actually prevents the eruption of the associated or the adjacent permanent tooth, okay? So how would we treat it then? What should we do? Send it to an oral surgeon, right? And what is the oral surgeon going to do?
Remove it.
They basically remove it, surgically remove the entire thing. And then they're going to create a pathway for the permanent tooth to erupt. Okay? Because if you don't take that out, the permanent tooth is never going to come out in that area. Okay? It's not going to resolve on its own. It's commonly seen in younger patients, okay, younger than 20 years of age. Again, in your list of entities that are seen in patients younger than 20 years of age, compound and complex odontomas are some things I would include. Okay, they're usually asymptomatic. What do we see here?
Whoa. Radiolucent radiopaque mixed lesion with multiple.
Is it a radiolucent lesion, radio-opaque lesion, or a mixed lesion? Mixed, okay. Why do you guys say it's a mixed lesion? Where is the...
There's a radiolucent border.
There is a radiolucent border. Majority of it is radio-opaque, but you have what looks like a radiolucent border right around, some of that lesion, right? So this is considered a mixed lesion. And remember what I said? Both with compound and complex odontoma, they both present as central radiopacity surrounded by a peripheral radiolucent rim. Okay, that's typical presentation. If you don't see a radiolucent radiolucent rim, don't call it odontoma, okay, a complex or compound, because typically you have to see a radiolucent rim. What is it doing? It's again preventing the eruption of the permanent tooth, right? Right there in your second molar. Yes.
Is that a dentigerous cyst on the maxilla?
Okay, so it looks like there is a radiolucency, around the crown of that tooth, right? How do we know that's a dentigerous cyst or just a normal follicle? Because every erupting tooth is going to have a follicle around it, right? How do we differentiate between a follicle and a dentigerous cyst?
It's impacted.
You have to measure it. So if it's greater than 4 millimeters, the likelihood is it's a cystic process. If it's less than 4 millimeters, most likely it's a hypoplastic follicle. Okay, but your x-rays have to be calibrated before you can say, what the measurement is. Without a proper calibrated x-ray, you cannot take a good measurement. Okay. So which one is a compound odontoma in these two pictures? Is it on the one on the top or the bottom? Left or right? Left. What type is it? Compound odontoma, right? Because you have multiple teeth-like structures with a radiolucency around it. And look at the center of each of those radiopacities. It looks like a radiolucent line, right, in the center. That's actually the pulp. Okay. And this one is a complex odontoma. This has a predilection for posterior mandible. You're seeing it as a disorganized radiopaque mass, and then with a radiolucent rim around it. Okay, so it's important to know the difference between compound and complex odontoma radiographically, because if you do not specify the subtype, you're not going to get credit for it, even if you write odontoma. Okay, so same thing here. You've got odontoma right there, and these are from your textbook. This is a compound odontoma, and this is a complex odontoma. And look at, it just looks really excessive right there. Okay, so, and this is, if you took a biopsy of it and histology, you're going to see all the elements of the tooth. So this is your dentin. You're going to see the pulpal structures in the center, and enamel usually gets washed out when you look at these odontomas. Okay, the treatment is basically excision, and the prognosis is pretty good with odontomas. Okay, so far we talked about odontogenic tumors, and then we covered entities that belong to tumors of odontogenic epithelium origin, epithelial and mesenchymal in origin, right? So which ones do you include in benign odontogenic tumors of epithelial origin? Which is the most common one? Ameloblastoma. So conventional ameloblastoma is the most common benign epithelial odontogenic tumor, and if it is also the most aggressive among all the odontogenic tumors that we talked about so far. And the treatment, that's why, is extremely aggressive for a conventional ameloblastoma. How do we treat a conventional ameloblastoma? Marginal resection. That's critical. Saying that you do resection is the most important thing with conventional ameloblastoma, right? And how much of a margin do you have to take when someone is doing a resection?
1 to 2 centimeters.
1 to 2 centimeters past the radiographic margins. Okay, And what was the other one that we talked about, which is also a benign epithelial odontogenic tumor? Another type of ameloblastoma, unicystic ameloblastoma, right?
Yeah.
Then we talked about AOT, which is the adenomatoid odontogenic tumor. And we talked about CEOT, which is calcifying epithelial odontogenic tumor. So these are all considered odontogenic tumors that are benign and that are epithelial in origin. And then we have two entities that we talked about that are epithelial odontogenic, they're mixed odontogenic tumors, but that are benign, okay? So one of them is ameloblastic fibroma, and then the other one is odontoma. And odontoma, are they one type or two types? Two types. What are the two subtypes of an odontoma?
Complex and compound.
Compound and complex, right? Compound has a predilection for what part of the jaw? Anterior maxilla. And complex has a predilection for posterior mandible, right? All of these entities except conventional ameloblastoma and calcifying epithelial odontogenic tumor have a predilection for younger patients, okay, patients younger than 20 years of age. If you saw a unilocular radiolucency around an impacted maxillary canine and it's a teenage female, what would you consider in your differential diagnosis? AOT, adenomatoid odontogenic tumor, okay? And if you saw a male, a teenager, and then you see a unilocular or a multilocular radiolucency around an impacted molar in the posterior mandible, what would you consider in your differential? Multilocular. If I say, forget unilocular, if it's a multilocular radiolucency. Younger than 20, you see conventional ameloblastoma? Ameloblastic fibroma. So if it's a male, younger than 20 years of age, and has a predilection for posterior mandible, you see it as a multilocular radiolucency, it tends to be usually, you have to consider ameloblastic fibroma in your differential. Okay, your next entity is odontogenic myxoma, right? So myxoma, it basically arises just from the ectomesenchyme. So the epithelial component is normal here in an odontogenic myxoma, okay? So this is just ectomesenchymal in origin. This is important entity. Why? Because it mimics a conventional ameloblastoma, an odontogenic myxoma, radiographically. It commonly presents as a multilocular radiolucency. Remember the acronym MACHO? M stands for myxoma, which is your odontogenic myxoma. Okay? So what do you see here?
Posterior
mandibular.
Is it just in the posterior mandible, the lesion?
Throughout the whole mandible.
It's actually involving pretty much the entire mandible, whatever you can see here, right? So it's going all the way from anterior mandible here, going to the third molar, right? So is it unilocular or multilocular radiolucency? It's a multilocular radiolucency. Are these large loculations?
Yes.
Okay, so what kind of a radiographic pattern would that be?
Soap bubble.
Soap bubble, right? So this is the soap bubble type of multilocular radiolucency that you're seeing that's involving a significant portion of the mandible, okay? And it's also causing displacement of some of the teeth, okay? So if you saw a multilocular radiolucency like this, what would you consider on the top of your differential diagnosis? Conventional ameloblastoma, right? But then this is an odontogenic myxoma. You also have to consider odontogenic myxoma in your differential. They tend to have predilection for mandible more than maxilla. They tend to be more common in patients younger than 30 years of age. So between 20 to 30 years is the range typically. But the big problem with odontogenic myxoma is the growth. Okay, they have this really slimy kind of material that actually contributes to this excessive growth in an odontogenic myxoma. Okay, so when a surgeon does a biopsy, basically they'll describe the material as a gelatinous kind of material. Okay, so the myxoma basically contains this really gelatinous material that kind of infiltrates pretty much wherever it sees a space, you know, to kind of go into in the bone. Okay, so that's why they tend to be aggressive. again, all of these examples of myxoma that you're seeing, you can see that they are expansile lesions, right? So they're pretty large. They're multilocular radiolucencies with these large soap bubble kind of loculations, and it's actually displacing the tooth from its normal position. Okay, and so that's one of the features that you see with myxoma. Again, same thing here. What did it do? It actually displaced the tooth to the inferior border of the mandible here because of this lesion. What is it doing here? It pushed the tooth into the sinus. Okay, so these are pretty expansile lesions, and because of the gelatinous nature, they get pretty large pretty quickly. Okay, so one thing that's different about these septations in a myxoma, they tend to be more linear and kind of straight. Whereas in an ameloblastoma, they tend to have typically a curvilinear septation. So it has like a C shape to it. But these tend to be a little bit more thinner. And they also tend to have some of these linear kind of septations in them. Okay, so especially this example, you can appreciate this. You can see here how it looks like, linear septations. And this is a multilocular radiolucency. And it looks like the steps of a ladder. Okay, so this pattern, it's called step ladder pattern that you see. So it can either have the soap bubble kind of radiolucency, or it can have the step ladder kind of radiolucent appearance in a myxoma. But the critical thing is that gelatinous nature and the ability to infiltrate the bone and then become really expansile really quickly. Okay, they can also mimic. What is it mimicking now here? A lateral periodontal cyst, right? So they can also do that. They can mimic a lateral periodontal cyst. And this one, it's mimicking, it's a multilocular radiolucency. So what is it mimicking? A conventional ameloblastoma. It's mimicking an odontogenic keratocyst, because they both can present like this. But here the septae look much thinner compared to a conventional ameloblastoma, and it doesn't have that anteroposterior kind of growth pattern like you typically see with an OKC. So this is the kind of material that you see in an odontogenic myxoma. So this really bluish kind of hue that you're seeing in the stroma is what basically gives it that gelatinous appearance. Okay, so. And then same thing here. The stroma is really loose, and there's not too many cells here. So that's why it gets that gelatinous appearance or myxomatous appearance. Okay. So the big thing with odontogenic myxomas is the size of the lesion. So if it's a smaller lesion, you can just curettage it, but you periodically follow up these lesions, right? But if it's a larger lesion, because they have a tendency for aggressive growth, okay, and because of the nature of the material that it infiltrates the bone, you have to do a resection. Okay, you cannot just do a curettage in a large odontogenic myxoma. The reason why? Because these lesions, they don't have a capsule. Okay, so they infiltrate the bone, and it's really hard to tell, how much of the bone gets involved, because they grow pretty aggressively and pretty fast. Okay. So typically you do resection for that. If you see a myxoma in a posterior maxilla, this is a much harder area to treat because of the vital structures that are in that area. The problem with odontogenic myxoma is the recurrence rate, right? It tends to have at least a 25% recurrence rate because, again, of the nature of the material that this tumor is composed of. Because of the gelatinous nature, it has a tendency to infiltrate the bone. So when this lesion is being treated, the likely possibility is not everything is taken out. Okay, so that's why it has a tendency to come back. But it has good prognosis once everything is removed, though. Okay, so odontogenic myxoma is basically a benign odontogenic tumor. This is what is the origin for it? Is it epithelium, ectomesenchyme, or is it mixed?
Ectomesenchyme.
It's ectomesenchyme, right? So what is the site predilection for an odontogenic myxoma? Site. Posterior mandible, right? What is the most common radiographic presentation of an odontogenic myxoma? It's multilocular radiolucency, okay? And what are the two different ways you can see this multilocular radiolucency? One is soap bubble type or the step ladder pattern, okay? And how do you treat an odontogenic myxoma if it's a really large lesion? Is with resection. What other odontogenic tumor that we talked about is usually treated with resection? Conventional ameloblastoma. So both conventional ameloblastoma and odontogenic myxoma are commonly treated with resection. Okay. So this is our last entity. So this is called cementoblastoma. Okay. So cementoblastoma is also an odontogenic tumor that's benign, but this is also arising from. So when I say cementoblastoma, what do you think is the origin? So it's related something to do with cementum, right? And cementoblast. Okay. So this is also an ectomesenchymal tumor. So in your classification scheme, when you look at it, myxoma and cementoblastoma, they fall under the ectomesenchymal origin in the table, right? So cementoblastoma, it's not very common. It's less than 1% of all the odontogenic tumors. But the critical thing about this is its radiographic presentation and its predilection for the mandibular first molars. So most of the times you see cementoblastomas associated with mandibular first molars. Okay. So what do you see here? Is it radiolucent, radio-opaque, or mixed? You guys have to make up your mind. Is it radiolucent, radio-opaque, or mixed? Mixed. Mixed. That's good. This is a mixed lesion. Why is it a mixed lesion? What is the majority of the tumor have? Radiopacity or radiolucency? Radiopacity, right? So majority of the tumor looks radio-opaque, but then you have some areas that look radiolucent mixed with it, but it also has a little bit of a rim that's radiolucent around it. Okay? So remember I said there are a couple of entities that we'll talk about today that present as radiopacities with a radiolucent rim around them. Cementoblastoma is one of those. What was the other one that presents as a radiopacity with a radiolucent rim? Odontoma. Odontoma also presents as a radiopacity with a radiolucent rim. Okay, so cementoblastoma appears as a radiopacity with a radiolucent rim. So does an odontoma. But it's really pretty much impossible to mistake a cementoblastoma with an odontoma, right? A compound odontoma has its characteristic radiographic appearance, small tooth-like structures with a radiolucent rim. A complex odontoma, on the other hand, is not usually seen at the apex of a tooth like this. Okay, so it's seen usually on the coronal aspect of the tooth. So it prevents the eruption of the tooth, right? So that's why you don't get those two confused with each other, even though they both can present as radiopacities with a radiolucent rim. Okay, so now when you see it as this, okay, what other features do you see here on the radiograph?
It's resolving the root.
Okay, so it looks like it's resorbing the root of the tooth. Okay, but what tooth root is it affecting?
The
19.
So it's tooth number 19. So mandibular first molar, distal or mesial? So it seems to be more merged with the distal tooth root here, right? So what you see is you have a PDL, periodontal ligament, right, running all the way up to where the tumor basically starts. The area where the tumor starts, okay, so you see the PDL here, okay, all the way, and then once the tumor begins, you lose the PDL. So it actually merges with the tooth root, and that's critical. In order to make a diagnosis of cementoblastoma, you guys have to see that the mass actually merges with the tooth root. I just want to make one little announcement. It's really essential to pay attention in class because this is not information that you're going to get when you read handouts or look at your PDF PowerPoints. Okay, the ability to distinguish between things. If you assume that you can do that on your own, unfortunately, I have to tell you that you're mistaken. So it's really critical to pay attention, because you won't be able to apply this in your exams and quizzes. And that's when the trouble comes, right? When you cannot do a good differential or a definitive diagnosis. So if there's something that you need to discuss, it's better that we do it outside the classroom, not in the classroom. Okay, so what do we see here? So we said that, you know, the PDL, right? How it runs from here, and then you start losing the PDL, and you have mandibular first molar, and the mass is completely merged with the tooth root. And that's a critical thing, because there's another entity, and I'm not sure if Dr. Richards will cover for you. It's called osteoblastoma. Okay, so if I took a biopsy of this and I looked under the microscope, a cementoblastoma and an osteoblastoma are going to look exactly the same. The only way we can differentiate between them is whether it's merged to the tooth root or not. So radiographically, if it looks like it's merged with the tooth root, then it's a cementoblastoma. An osteoblastoma is independent of the tooth root. Okay, so you always have to see basically loss of PDL where the tumor begins. Okay, so you're not going to see the PDL, and you'll see a radiolucent rim with that central radiopacity. The site predilection for a cementoblastoma usually is a mandibular first molar. So 80% of the cases occur in the mandible, and 50% of all cementoblastomas are actually associated with the first molar, mandibular first molar. Okay, this is again something that tends to affect patients who are younger, so younger than 30 years of age. Okay, so 50% of the cases are before 20 years, and about 75% of the cases are below 30 years of age. So typically you don't see cementoblastoma as commonly in someone older than 30. Okay, but one of the other features that you see with the cementoblastoma is the pain. They actually have pain associated with the tooth. So what do we see here? It looks like a tooth was extracted along with this mass, right? And it's basically sectioned in half, and you can see all the elements. Okay, and this is where you see how it merges with the mass, the tooth root. Okay, and you can't even distinguish on both sides where the tooth ends and then the mass begins. And that's the critical thing with cementoblastomas, is not being able to distinguish where the tooth ends and the mass begins, right? It merges completely with the tooth root. Okay, so that's why, and that's important. Why? Because when surgeons go in to treat a cementoblastoma, they cannot just excise the mass, because what happens is it merges with the tooth root, so they typically have to extract the tooth along with the mass that's associated with it. Okay, but there is another option. If it's only associated with one root of the tooth, the mass, what they can do is just amputate that tooth root that it's associated with, and then they leave the rest of the tooth in the mouth. Okay, and then they'll do intentional endodontic treatment, but that's not the most preferred treatment. So in your quizzes and exams, if there's a question on, how do you treat a cementoblastoma, preferable treatment is extraction of the tooth along with the mass, right? So that's your preferred method. So this is what you'll have to do, because the mass basically merges with the tooth root. Again, what are the features that you're seeing here that helps you make a diagnosis? And this is a definitive diagnosis. This is not a differential. If you see this radiograph on a quiz or an exam, you need to be, or in a patient, a real patient, you need to be able to make a diagnosis right away without having to give a differential. Okay? Why? Because this is associated with a mandibular first molar, and it's associated with one tooth root. Okay, and it looks like it's merging with the tooth root here. You cannot distinguish between where the tooth ends and, the root ends and then the mass begins, and then it's seen as a central radiopacity with a radiolucent rim around it. Okay, so it's satisfying all of those criteria. Okay, and this is another example. And what did they do here that shouldn't have been done? Endodontic treatment. Why? Because in cementoblastomas, what happens is when initially the tumor begins, it starts off as a radiolucency, right? And over a period of time, as it calcifies, it becomes more radio opaque as it matures. Okay, So what happens here? So it probably presented as a radiolucency at the apex of this mandibular first molar. And ideally, what should be done? What should be the next step if you saw a radiolucency? You extract if you see a radiolucency at the apex of a tooth.
No.
What should be your next step? You have to make a diagnosis, right? How will you diagnose what the lesion is? Before you do a biopsy, what would you like to do?
Measure it.
Before you measure it, what would you like
Oh,
to
you
do?
see if it fused with the PDL.
No, you have to check the vitality of the tooth. You have to see if the tooth is vital or not, right? Because if it's a vital tooth, what is the purpose of doing an endodontic therapy? Because that means it's something that's developmental in origin, right? That radiolucency that you're seeing, it's not inflammatory in origin. So that is the mistake is people make is when they see a radiolucency, it should never be automatically assumed that it's inflammatory in origin, that it's something to do with the tooth, right? It could be developmental. So once you check the vitality of the tooth, which probably was not done here, and then ended up getting an endodontic treatment on something, and that's not going to resolve this lesion, right? Because this is a developmental tumor. So the way you treat that is by excision. So this is what you would see histologically, is basically the tooth, and then this is all the tumor that you're seeing here. And this, if I didn't have the tooth on the top, there's no way for me to tell if this is a cementoblastoma or an osteoblastoma, right? Because they look exactly the same. But now I see that the tooth root is actually associated with the mass right here. It's actually merging with the mass right there on this distal root. Okay? And this area that looks like a radiolucent rim is actually an area that's not calcified. That's why it looks radiolucent. And the area that's calcified looks radiopaque. Okay, so our treatment for a cementoblastoma is basically extraction of the tooth along with the attached mass. And as I said, some do endodontic therapy, but this is not the most preferred method. So cementoblastoma, things to remember is its association with mandibular first molar. Okay, that's when majority of the cases are. It usually presents as a radiopaque mass with a radiolucent rim around it, and it's usually merged with the tooth root. Okay, you cannot distinguish, where the tumor begins, in these lesions, because they completely merge with the tooth root. And the way you treat them is basically excise the mass along with extraction of the tooth root. Okay, that's usually the preferred method. So cementoblastomas are usually mesenchymal in origin. These are not, something that originates from epithelium or mixed tumors. So in your odontogenic tumors, please know your classification scheme and know the entities that fall under each of those classifications, the ones that I've highlighted when we first talked about it. And then you need to know histology for ameloblastoma for sure, because that's something, it's very critical entity to know about, and even though it's benign, it's very aggressive. So you need to know how to diagnose it. Okay, do you guys have any questions? Because I am done.
How does that go with the endodontic treatment? How does that go with the standard of care?
I'm sorry?
If they didn't do a vitality test.
That's not considered standard of care, right? So that is something that could go to become a medical legal case. Because, and that's not the appropriate steps that the dentist has taken in order to establish a diagnosis. So if that ever goes to court, who do you think is going to win? The patient, right? Because that was not appropriate standard of treatment.
For odontomas?
Yes. Go for it.
So for odontomas, it's a compound. It's usually in the anterior maxilla, right?
Yeah. Compound odontoma typically tends to be anterior maxilla.
And complex is posterior maxilla.
Posterior mandible. That's right. Sorry. Go. Yeah.
So I remember you said that there's like either it's like mixed, but what
It's a mixed origin, but radiographically it's always radiolucent. So radiographically it's never mixed.
white to me, but why do you call it as like radiolucency?
So the white that you're seeing inside that radiolucency is your bone, normal bone that's dividing the tumor into like different globules. It's normal bony septum, right? So it's not actually the tumor. It's not a part of the tumor. The tumor is the tumor is not making that white stuff, right? Yeah, it's just bone.
So you
That's
call
in
it
the
as
area.
even though it looks like white.
Yeah, it's either bone or fibrous septae. Sometimes fibrotic tissue also can, form like these septations in the jawbone. So, but it's not the tumor is not forming that product, that white stuff.
So that's why we call it radiolucency.
Radiolucent.
Even though there it looks like plastic, like
It
white.
doesn't look like so there's a difference between something that's so it's increased in density, yes, you're right, but it's not a radio-opaque tumor, it persists, right? That's the difference.
So you said this one is this is a mixed region.
It's a mixed lesion by origin, not by radiographic appearance.
There's two things like this.
You're welcome.
Ameloblast fibroma, and then what was the other one? There's a
Odonto, yeah. So if you look at your, but if you look at your, if you scroll up all the way, where the table is, here, I will tell you. So the ones that are mixed are ameloblastic fibroma and odontoma. The ones that are just mesenchymal in origin are myxoma and cementoblastoma. And the ones that are epithelial in origin are just these, these are